Again, core, pre and post color. In this example of a 39-year-old with hepatitis B, there was a liver lesion we suspected to be hepatocellular carcinoma. We were asked to do a biopsy. We were asked to do a core. You can see the color flow pre, and then color flow post. And I saw this interesting tract that came out to the liver surface. I went ahead and placed Doppler onto that tract, and it looked like it may be arterial or some type of venous flow. I compressed for 5 minutes, and eventually that stopped. This has been coined the patent tract sign. It was published in AJR in 2007. When they looked at this occurred about 10% of the time with core biopsies of the liver, and at about 1% of the time it persisted for greater than 5 minutes. When they analyzed venous versus arterial waveforms, if you had an arterial waveform, it was not good. Those were much more frequently associated with bleeding than those with a venous waveform. Here's an example of a 63-year-old male who had hepatitis C. I've been doing RFA for a number of years, and I did a RFA of a hepatoma in 2003 without a problem. I did another RFA of a separate hepatoma in 2005. In 2008, he presented with 2 hepatomas. You can see these new enhancing masses, one on CT to the left, and this is the image of the ultrasound on the right. In this case, this demonstrates the needle being placed for the potential RFA. You can see the slightly hypoechoic lesion. Here's the needle as we place it, the fairly echogenic needle, and you can see the more hypoechoic lesion. And then this is as we do the RFA, you can see the needle in which it becomes very echogenic at the site in which I place the needle all the way through the lesion to do the RFA. Now I start my pullback, and during my pullback I'll also cauterize the tract to prevent any potential bleeding. And as I pull back, you can see as I pull back all the way, I will stop and cauterize that tract. But what I find with color flow post, and you have to look very carefully at the capsule, there's a very small area of increased color flow. As I mag that image, you can see the color flow here as a very small bleeder that occurred and went subcapsular. Unfortunately, when I did Doppler through this, it was basically an arterial bleeder. Now you ask the question, what do you do? And as I told you, the history, the patient was a Jehovah's Witness. And in fact, I asked his wife, because he was under anesthesia, can I give him blood products? And the answer is absolutely not. He did have slight elevation of his INR, so there was nothing I could do. So we went ahead and embolized this patient very successfully. So the real question, what would have happened to this patient if we did not monitor with color flow or perform the procedure under CT guidance, and we have not known there was an active bleeder in this case? So ultrasound in this case with color flow post-procedure was very helpful. Finally, again, consider color flow with random biopsy. In such a case here, in renal biopsy, the same sort of thing can occur. These are sort of the patent tract sign, but this occurred after a random biopsy of native kidneys. They, again, demonstrated vascular abnormalities in a higher percentage of the patients, about 20% of the patients. Here's a 33-year-old male, status post-renal transplant, possible rejection for a biopsy. This is we go ahead and do the biopsy through the cortex post-biopsy, and you'll note the times on here. This is 9:38 a.m. We go ahead and eventually do some compression through there, and as the time goes on, this site of increased color Doppler or increased bleeding decreased with time to the point of 9:48 a.m. and it completely stopped. When will we do combined FNA and core? Well, we do it in a number of different cases, and we sort of have to say, we want to get an adequate diagnosis or do we want to minimize complications? So we're sort of teetering between this all the time. So open biopsy will get an adequate diagnosis, but FNA core, you sort of want to minimize complications. I use a coaxial technique here because it does provide a margin of safety. And that margin of safety is, if I note a lot of bleeding, I can go ahead and do a gel foam slurry and inject gel foam into my needle, or do a blood patch injection. 80-year-old with breast cancer. This is question liver mets, question abscess. Put in my initial needle. This is what it image looked like. My coaxial needle that I was going to put in is 17 gauge, and then I'm going to do potential core. And this shows as the initial needle is placed into the lesion, aspirating all the central fluid. After that, I go ahead and I place another needle, or I reposition that needle, and now I'm going to go ahead and do FNA through that. After I've done FNA into the solid portion of the lesion, I'm going to go ahead and do core. And with both FNA core, we found that this was not infected at all. This was a necrotic metastatic adenocarcinoma. Here's another patient, transitional cell of the bladder with liver lesion, called likely a MET. You can see it on ultrasound, on CT. We went ahead and did a 22 FNA and a core, and we did a coaxial technique, but we got bleeding afterwards. What I did in this is, in fact, I went ahead and used the blood patch technique, or you can use the gel foam slurry. We thought questionably after this was a cavernous hemangioma, but even if you had biopsy cavernous hemangioma, you could still use this gel foam slurry or the blood patch technique if you have a needle in there, such as a biopsy guide needle, where we go ahead and do a core and FNA. I'm going to show you two special techniques, not specifically utilized with ultrasound, but with CT, use of a blunted needle and use of hydrodissection. Here's a case here of a 35-year-old female with cancer, and there was two hot areas identified on PET in the peri-aortic region on the left-hand side. CT on the left, and then we put her in the prone position, and left is over to your right. And these areas where we're going to biopsy are very close to the hydronephrotic ureter. We only have a window there of less than 1 centimeter. In this case, we went ahead and I did a biopsy using a coaxial technique with a blunted needle. So I used the sharp interstylet to go through the muscle, but when I get into a critical area, I'll go ahead, put in the blunted tip, and go ahead, push gently down through that area and push the ureter out of the way, take out that interstylet, and then do multiple FNAs. And this unfortunately turned out to be cervical cancer. Another patient here who had a renal cell carcinoma, and on the left-hand side there was an adrenal enlargement. This is thought to be a question adrenal metastasis. Went ahead, set him up for biopsy. I was going to use the left-hand side, but there was no window between the spleen and the colon. So what I did here is I took a 21 gauge injection needle, injected some water through there. You can inject D5W in these cases. Injected to displace the bowel and the spleen in such a way that I eventually had a window. Went ahead with my needle here. You can see as my needle is going in, eventually got in and to that, and this turned out to be with FNA metastatic renal cell to the left adrenal. Well, in summary here, I would say probably one of the most important things for you to do is to do color flow pre and post. So you can do it pre to note the route you're going to do, and you can do post for potential complications. Again, I would emphasize with ultrasound, think about that coaxial technique for needle placement. In case you do get into complications, that will be helpful. Thank you very much.